whether it is home care, whether it is care in the community, whether it is multidisciplinary care, end of life, advanced care planning, ICU management. And so we have our cases kind of trying to cover all these aspects. So stay tuned. It's going to be a very interesting discussion. Like Ishaq said, we will leave some space. We will leave some time, about 5 minutes after each case for discussion, and then hopefully we will have about 10 minutes in the end to be able to for any queries about the case, and otherwise also we have another lecture coming in, the last one, which is on establishing a pediatric palliative care unit. So if you have questions regarding that, know that we have a whole lecture on it in the future, next Saturday. So without further ado, I'm going to ask Dr. Veronique to start with the first case. And I think that, Vinila, even though you have the lecture, if you don't mind, I will share screen from here and share lecture.
You can go ahead, ma'am.
Okay. Is the PowerPoint seen?
Yeah.
Yes, ma'am.
Yes, I can see it. Yes. Thank you, Smriti. So the four speakers, the four presentations are going to be given by four speakers you have met in the course of this certificate course. That is myself for the first case, Smriti, Sabita, and Mohamed Ishaq. So the first case is going to be a cardiac case. We met this first 4-year-old girl with a complex cyanotic cardiac, cyanotic congenital heart disease, was referred for palliative care in August 2022. So in relevant past history was cyanosis and existence of cyanotic spells since birth. And she was diagnosed at the age of 2 months with a complex cardiac malformation, that is double outlet left ventricle, along with transposition of great arteries, with ventricular septal defect, with pulmonary stenosis. Due to the complexity of the condition, the cardiac surgeon said that 3 surgeries would have to be done in the course of several years, starting immediately, because at the first cyanotic spells, actually, you are supposed to do the first intervention. And then further on, because not everything can be corrected at such a small age when the heart is very small. So the family decided not to go ahead for any surgical intervention for the heart. And in order to decrease the frequency of cyanotic spells, she was put on CPLAR. And then she had developmental delay. So already we can assume that because of at each cyanotic spell, maybe something would maybe migrate to the brain. She could not walk, she could not stand, but she could hold objects. And her speech was just monosyllables at the age of 4 years. So the present hospital admission, she was admitted about a month before being referred to us with paucity of movements sorry for the misspelling, of the left upper and lower limbs since the past 3 weeks. So she was on admission in the emergency department. She was having mild tachycardia, tachypnea, BP was normal, but her saturation was 56%. So she was deeply cyanosed with grade 4 clubbing, and she had decreased tone as well as decreased power in the left upper and lower limbs. Knowing that right upper limb and right lower limb powers were also a bit diminished, and the reflexes were high. So CT of the brain showed the presence of 3 large abscesses in the right frontal cortex, which were finally drained. In order to allow regular drainage, the hole was left open by the neurosurgeons. So she had a large bandage around her head, and that was regularly changed. So post-operatively, antibiotics were given, and a pseudomeningocele formed. So that's why that regular drainage of natural drainage, there was no artificial suctioning being done, was allowed to happen. She became septic, Acinetobacter grew in the blood culture, so antibiotics were upgraded to meropenem, teicoplanin, and fluconazole, as well as levofloxacin. There was persistent thrombocytopenia related to sepsis, and no improvement in the clinical conditions. In the meantime, she required 2 shifts to the PICU, pediatric ICU. And when we were called, the next slide, please. When she was referred finally to the palliative care, so after a month of hospital admission, she was 10 kilo. She hemodynamically stable, but with the cyanosis. She was having respiratory distress. Saturation on high flow oxygen was only 60%. Was conscious but poorly responsive and unable to sit up. She was groaning, so there was some probably some pain was present, and that dressing around the skull was continuously oozing, partly related to that persistent thrombocytopenia. So there was some pus mixed with blood. A murmur could be heard, and the chest was clear. So most importantly, the psychosocial assessment and the reason for the call was related to the father's mood. He was very volatile, very aggressive, and he showed a lot of very, very deep attachment to the child. He was the sole decision maker. The mother was there, but was not saying anything. She was very worried for her child when we took her aside so that she could express herself, but she was in control. Both the parents were on denial mode, saying the seriousness of the condition. And they were really refusing to speak to any of the treating doctors. So the pediatricians, pediatric, in the ward, they were unwilling to put the child through any more pain, and a bit ambivalent in the decision. Do we accept to take her again to the ICU, or what do we do? So the child was conscious, interacting intermittently, but she wanted to meet the family members, especially her older sister. So the family was a lower middle class family. They had financial concerns. The father working in a grocery shop, and the mother being a housewife. And the parents were concerned about the care of the older sister, who was left with a grandmother. So this, the intervention of the palliative care team started with planning a joint counseling of the father with all specialties involved, along with the medical director, medical superintendent, pediatric neurosurgeon, neurologist, and cardiologist, as well as from our team, a physician and a counselor. So first, the parents were updated on the child's condition, that the dressing for the skull wound was to be done every 2-3 days, but there was no local infection. The blood cultures were fortunately negative, so sepsis seems to be under control. And then the reiteration that there was no plan for cardiac surgery at this stage, 4-year-old. And the parents, maintain that decision. They don't want to increase the child's suffering. And they had been told from the beginning that the lifespan would be limited to about 5 years. So they were hoping to have some more time with her. And we also addressed the concerns about pain management because paracetamol was being given round the clock and did not suffice. So we decided to start morphine. So after this meeting, the parents So the pain management, we added to the paracetamol morphine for hourly and bisacodyl to prevent constipation. And actually, we were happy that thinking of the added benefit of morphine on the breathlessness that she might be experiencing because of the respiratory distress, and also on the cyanotic spells. So we know that the benefit of morphine on vasodilatation of the pulmonary artery that reduces the preload and the pulmonary congestion. Before going to the next, go back. To the next slide. I want you have had already some session about breathlessness. So just try to recollect and maybe to put on the chat, what are the mechanisms of action of morphine in dyspnea? Or at least you try to remember how you have been explained. And how you can explain another colleague who would tell you, no, respiratory breathlessness, you cannot give morphine. I don't know if there are things on the chat. So we'll go to the Smithy to the next slide. Thank you so much. So morphine, as you know, reduces the hyper-responsiveness to hypercapnia and hypoxia by diminishing the chemoreceptor sensitivity. And it also decreases the subjective perception of dyspnea, as well as anxiety, which plays a very important role in the cycle of respiratory, breathlessness. It also decreases the respiratory drive, but without reducing the respiratory rate or the oxygen saturation. And it decreases also the oxygen consumption because of vasodilatation in the lungs. It will have a very beneficial effect also on decreasing the oxygen consumption. And in a child who is having cyanotic heart disease, that will also be an added benefit. So in cyanotic spells, we know if there is an ongoing hypercyanotic spell, that intravenous or subcutaneous morphine is really a wonderful drug because it helps calm the child down, and sedation is one of the goals in order to reduce the oxygen consumption. It reduces tachypnea. It decreases the pulmonary vascular resistance. So depending on the setting, other cardiologists prefer to use injectable ketamine. And then the neat chest position, as we all know, helps also to decrease the pulmonary pressure and to increase the systemic pressure. So that's where you see that really the morphine also is a great medication in this setting, sorry. So in the subsequent days, our patient's pain behavior decreased, her respiratory distress also, because all the abnormal breathing respiratory movements also are usually respond very well to oral morphine. The father, who was initially ambivalent when we were discussing the goals of care and the option of non-escalation, finally agreed to discharge the child home on oxygen concentrator or end-of-life care at home. What we really thought was end-of-life care. Her saturation was 45% on oxygen. She was drowsy. And so we planned regular home care visits from the next day onwards to see their home, how they were managing, and also to do the skull wound dressing and to be able to train them because we didn't really have much of time for that training. No, we looked after her for 4 days, and then she was discharged. And then we already spoke to them about how they would what they would do in case of emergency, and in case of death, how to get the death certificate. So they had already planned from the local pediatrician. And the medications which we gave at discharge was against medical advice as per the hospital rules, because the child was, as we thought, actively dying. even though we prefer to have palliative discharge and not again against medical advice. She was discharged on morphine as well as diamoxodamine and oral antibiotics and antifungals. So subsequently, when we went home, we went for 4 home visits. The nurse and the counselor, just after discharge, the parents, especially the father, express a lot of regret about doing the brain surgery for the abscesses, for draining the abscesses, because the whole condition of the child was really bad, and she needed a 1-month hospital admission, and they were getting ready to lose the child. So she was deeply cynosed, and then the oozing was ongoing. So we taught them about how to do the dressing. She had overall all body swelling, was fed by RT feed, and we prepared the parents for the end-of-life care at home. So it was great to see how her older sister was involved in care. We had great also interaction with her sister to prepare her for the demise of her sister. Later on, Smithy, the next slide, please. We continued the the nursing care, and could shift the oxygen from face mask, to nasal prongs, and then she could have more interactions with the family. Again, the care plan was reiterated, and the family was encouraged to make the most of the time left, spending quality time. But little by little, during subsequent visits, the child became more active, sitting up, talking, eating, and the parents had become comfortable to provide nursing care. So there was no need for our team to continue going there, but we continued on the phone, video calls and audio calls. So over 3 months, the wound healed, and the child was back to her baseline status. So it was really encouraging to see that even sometimes we think that we prepare parents for end-of-life care. It may not, it may not turn out to be the end of life. Subsequently, Smithy, yes, the next one. We see how she's like, this is a call, we spoke to the father 2 days ago, and this is her being strolled around. She cannot walk, but she's back to her 58-60% saturation of oxygen. She's playful. And then I thought, now, which reflections would you like to draw from this case? And there may be lots of ideas that come from the floor, which comments or questions. So you can unmute yourself, that will be easier. If you...
Hi, this is Deepika. Thank you so much for...
You're muted.
Yeah, can I say?
Yes, please, Deepika.
Yeah. Hi. Thank you so much, Doctor, for a very insightful case where, we do get to take home the message that, every life is important and every body should be given that right to live and be given the supportive care. My question was around the terminology being used, DAMA. What are the medical legal aspects of DAMA? Because what we have learned lately over the last couple of years is that it should either be a LAMA or a discharge. Even DOPR are not standard terminologies, and there could be many medical legal repercussions. So just your expert opinion on that.
Yeah, so in our hospital, we most of the time we manage to do a palliative discharge, which means that even a child at the end of life may come back to the hospital for a death certificate. And if it is within 24 hours, we do not need to have an NOC from the police. But after 24 hours, we need an NOC, but we do not need to do any post-mortem. In the case, so the DAMA discharge is when the hospital feels like nowadays, I think this year we have many less of DAMA discharges because the medical superintendent has understood the fact that it's not an immediate death. But if we have a patient who goes on ventilator, who goes home, and the child is ventilator dependent, and we have not managed to obtain the permission for de-escalation or withdrawal of intensive care. So the child was not extubated in the hospital. Then the hospital only accepts DAMA discharge. It's understood, of course, legally speaking, medical legally, the hospital is not totally free of responsibility, as you say, very, very clearly. But so I think it's something that should disappear more and more. I don't know if my co-chairs would like to add something, whether you have been able to get rid of the DAMA or LAMA discharge in your hospitals.
Something that I have understood from talking to palliative care units across the country is that in many hospitals that they are working, the rates of DAMA have reduced because either they could be because of miscommunication, mistrust, or financial issues, or family wanting to take home, but there being like a kind of a mismatch between what the doctors feel and what the family feels. So a lot of these, in a lot of these things, good communication helps. Sometimes the palliative care units actually help in transferring patients to units, to places where they would be sort of, where it would be more feasible or more easy for them to take treatment. So whether it is back to their rural setup or into another hospital also. Any other inputs, Ishaq or Dr. Savita?
Nothing from my end, Smriti. I agree. The DAMA rates have gone down.
You're not very, your voice is not very audible, actually.
I was saying that no comments from my end. Yeah.
Neither
Yeah,
from
neither from you. As Smithy says, as much as possible, if we transfer to another institution, then it would be a transfer. So that's something we try to do as a mid term, meaning otherwise when it is going home, at times we are really trying to get rid of the DAMA.
There is a question about, ma'am, please tell us more about palliative discharges.
Palliative discharge is when the treating team acknowledges that the decision made by the parents to take care of the child at home when the child is still needing some medical care. So that when the team agrees to that. So with the help of the palliative team, we plan everything for care at home. So whichever injectable medications are shifted to oral or sublingual or through RT. So that is kind of a discharge of a child who is not cured of his illness, of their illness, who may still need a lot of medical care, but that can be provided at home. So that's what we call palliative discharge, and it has been accepted by our hospital administration.
Dr. Vero, there is a couple of questions on home visits. In a resource-limited country like ours, how long are home visits possible and who monitors them?
So home visits are provided by teams that are palliative care teams, whether it is directly from a hospital, for example, or we tie up with other NGOs if the person is going for is living too far from our place. So it is monitored by the home care team, which in our case is the same as our, I mean, we have people on our home care, on our palliative care unit who are dedicated to the home care, as well as spending time in the hospital. So that can be most often it is done in concert with treating physician. So whether it is the hospital, for example, if we are dealing with a child with neurological condition, we may want to adjust the antiepileptic medications after discussing with a their pediatric neurologist. Yeah, so it has to be people, teams who know about providing home care, home-based palliative care. And Dr. Sabita will speak more about that in her presentation.
If we are already at 3:30, I think we'll go to the next case. And the next case will be delivered by me. And here we go. So I wanted to do one case on cerebral palsy. I mean, we are talking about cerebral palsy, but this sort of applies to children with severe neurologic illness, more or less. Even though cerebral palsy is actually a very broad condition with many implications in palliative care, I'll be focusing on some areas, including advanced care planning. So this case was of a 3.5-year-old child, severely malnourished and 7 kg at admission. He got admitted to our nutrition rehabilitation center with severe acute malnutrition. He had multiple vitamin deficiencies. There was scurvy, there was rickets, and he had contractures even at the time of admission. If you look at his past history, there was the history of birth asphyxia. We did not have too many details. The family were told right at the beginning that this child will not be able to talk or walk like any other normal child. And so they did not really consult too many medical services. The child did not receive vaccinations or doctor visits. We could perceive that there was a mistrust of hospitals when we spoke to them. And when asked why feeding, why this low weight, they told us about the prolonged feeding times. So given all this history, the treating team actually sent us a reference, one for home care and second for possible neglect of the child. Now, on physical examination, we could see that it was a case of spastic quadriparesis, so spastic CP. The child had scoliosis and bilateral ankle contractures. It was a so it was quite advanced. And but before we could complete our assessment, actually have a good rapport and start talking to the family, the father insisted on an early discharge. Even before nutritional rehab could finish. We also discussed with them other feeding options like Ralph's tube and G-tube or gastrostomy, but they said no. But what they said to us was that we don't want to do all this because changing the tube every few days or a month will mean that the child will go through a lot of pain. So now with the backdrop of this case and the issues that this child had and is going to be and is likely to have in the future, let's discuss a little bit about cerebral palsy. Yeah. Now, most of the children, we know what the definition of cerebral palsy is. Most children that we see fall under GMFCS level 4 or 5. They are completely dependent on all their day-to-day activities. And when it comes to complications of cerebral palsy, we will see many children having at least a few of them. So there can be spasticity, contractures, pain, seizures, issues with respiration and swallowing. There can be failure to thrive. There will be GI side effects. There can be behavioral challenges, fractures, sialorrhea or scoliosis, and menstrual suppression. And beyond this, there is a very huge psychosocial impact. And in this case, you could see some of this even with the short history that I have given. If maybe there was a caregiver burnout, there could have been a financial burden where they could not access physiotherapy services. The parents might undergo feelings of depression or punishment or parental guilt. and the child can be abandoned, or the child and one parent can be abandoned. There might be neglect, which is what the treating team thought in this child, and it might impact the other children also. And then this child will not have too much stimulation or education. But what are our goals of therapy when it comes to cerebral palsy? We are not looking at anatomical perfection. We are actually looking at what is functionally possible for the child and how we can enhance that. So if the child has scoliosis, we do not want to look at anatomic perfection of the scoliosis, but we try and help the child achieve better positions, try and help prevent contractures. So whatever is useful for the child in terms of mobility and balance, we try and work on that. Try and see how the child will be able to communicate with the family or with his siblings, his or her siblings. And we also look at interpersonal relationships within the family, and again, specific medical management, although I won't be covering too much of the medical management today. So we know that all these things can be done for malnutrition, even if the child is not in hospital and receiving a perfectly set nutritional rehab kind of course and diet. But these are some of the things that we can do. And children with swallowing dysfunction and aspiration, we look at the complication of recurring aspiration pneumonias. So trying to thicken feeds, making them from liquid to semi-solid, and positioning, and also then talking to them about NG tube or gastrostomy tubes. So children with feeding times, with prolonged feeding times, with history of recurrent pneumonias, history of aspiration and cough, NG tube and gastrostomy tube would be, or a gastrostomy tube would be a good idea. Now, for positioning, there are various types of chairs that are available that can be made based on the child's height and weight and body structure. And you can see here how you can have different kind of padded blocks or sandbags to help keep various areas straight. We have had patients with maybe not with CP, but with other severe neurologic illnesses who have also had kyphoscoliosis, and some of them have had torticollis, difficulty with keeping the neck upright, and the families have fashioned some kind of apparatus from a regular plastic chair and using padding all around to be able to help with the child's positioning, and positioning will then help with feeding, which will then help with aspiration pneumonias and things like that. Then children with poor balance or with uncontrolled movements, using a high chair with one or more straps, using kind of a box seat, even a box seat that can be made out of cardboard can help. Using multiple, sometimes just using a foot strap, all these things can be useful. For respiratory problems, many a times these children will try and get treatment at home only with local with oral antibiotics, and it can be caused by ineffective cough, it can be caused by aspiration, by GERD, and so that's why treating the GERD is important. Looking at starting IV or oral antibiotics promptly is important. Suctioning and nebulized saline. So now coming back to this child and what we did next, we had a very short interaction with them in hospital, but we planned for a home visit because a lot of these doubts and questions that we had in our mind would be better resolved in a home visit scenario. And so when we went, we found that actually the child was in a very loving environment. The mother and grandmother were the caregivers for the child, and they spent all their time with the child. The father would try and was the breadwinner of the family. He had an elder brother who was 7 years old, and every morning when the child, when this 3.5-year-old would be sitting in his grandmother's lap and would be getting fed, the elder brother would interact with him. He would make him smile, and we could see the difference by just having the elder brother in the room and around, and how he would perk up. So this is what I mean by improving communication and sort of trying to know the family dynamics and how the child was being taken care of. So from a family that was actually being accused of neglect, we could see that they were trying their best to take care of their child. And when we brought out the topic of feeding tubes again, they said that we are happy with what we can do for him. We feel that if we put tubes, then it's going to be very painful for him, and he may it may hurt him. The pain will be recurrent because of the needing to change the feeding tubes. And so that's a discussion that's still ongoing, but for the time being, we respected their views and went ahead. We taught them basic physiotherapy exercises that could help with avoiding further contractures, slow stretching. We are planning night splinting for the child, so that again, contractures can be avoided in the future. So this is something that we developed on the go in our home care team, a quick checklist for cerebral palsy, and we also use it for other children with severe neurologic illness. So as you can see, it's just like multiple small quick points, which at a glance, we will be able to, you can see the list and you will know what the child has. So we're talking about basic height and weight, feeding time, cough, type of feeding, what is the approximate caloric and protein intake, what kind of physiotherapy or mobilization is the child getting. The nurse has the GMFCS classification on her phone, and we've also printed it behind the chart, so it's easy to access. Is there scoliosis? Is there a clubfoot? What sort of medication is the child on? Is he on calcium and vitamin D supplementation? And how many admissions has the child had? What kind of communication is possible? What symptoms does the child have? We also have the RFLAC, and we have some spasticity scales on the back. So the nurse, and many of the spasticity scales are actually quite easy to kind of assess even by the nurse who goes on home visits. So we use Tardo, sometimes the modified Ashworth is used, and it's actually a very easy kind of way to assess spasticity. And so then we know what is the physiotherapy requirement, and we can try and work on that. And now the next thing that I wanted to talk about in children with severe neurologic illness and in a child with CP is exploring the topic of exploring the discussion of advanced care planning. So advanced care planning is nothing but exploring patients and families' views on disease progression and their preferences for treatment throughout the illness. And this will be even when the child is well or relatively well, and even during periods of deterioration. Now, although usually these discussions are triggered whenever there is an acute critical event, studies have shown that it's actually better to have these discussions during periods of clinical stability, and it is accepted well by parents. They appreciate being able to talk about what medical decision making they would like to take for their child at different trajectories on around the illness. So it could be if there is an intercurrent infection, it could be if there is an acute clinical deterioration, or if there is a slow deterioration, or even at the end of life. These are the various aspects of advanced care planning that these are the various kind of time points that we would want to explore in advanced care planning. And the way to do it is once we have done the discussion, we document it in the clinical notes. We reassure parents that they can change their mind anytime, although very few do. Most of them, once they have spoken and decided, they aren't confused anymore. And what has found to be helpful is good communication. So honesty in talking about their child and what kind of options they have for treatment, clarity in the different treatments available and the different ways of care, places of care available, and allowing the family time to absorb the information, not rushing in at one go, but giving them time and empathy. So this was about a little bit about advanced care planning, and maybe this is something that this is something that we will need to also explore with our family in the future. And I know that there have been discussions on communication in the in the past. We've had sessions on them, but this is especially a very good kind of ready reckoner that can be used. It's called as the Serious Illness Conversation Guide. It was earlier made for use in adults, and it has been adapted for use in the pediatric population. So basically, this is for use with parents of sick children. And there are a lot of aspects in it, but I wanted to just talk about a couple of things. So one is using the framework, I wish, I worry, I wonder, wherein we say that I wish that that your son or your daughter could lead a normal life like any other child, but we know that that's not the case. And I worry that at any point of time in the future, he may land up with an infection and be quite serious. And at that point of time, it will be very difficult for you to decide what kind of medical treatments would you be happy for him to undergo and what kind of medical treatments you do not want for him. And I wonder if we could sit and talk about these things. And usually the I wonder aspect is when we want to introduce any topic of discussion about whether it is discussion of goals of care, or if it is a discussion of withholding treatment at some point in the future. And then this other aspect about exploring key topics about goals and fears and worries. And this is a very important aspect, especially in cases in children with prolonged illnesses, non-oncological illnesses, because those illnesses have very uncertain disease trajectories. And so it's important to establish what goals do you think would you like to set for your child, so that we know that, okay, this is what the parents would want for their child. And then each time there is a deterioration, we see if we can reach those goals or if not. What abilities are so critical, what is so critical to your child's life that what is most important that he continues to do. So whether it is being able to play with his brother, or whether it is being able to eat by his mouth, we know that these are the wishes that the parents have for their child's life. So I think that this was it. This was my presentation on cerebral palsy and some of the aspects that were important, some of the practical aspects. So I'm going to stop sharing now, and we can again come back for another quick, say, 2 to 3 minutes of discussion.
So does anyone have any comment or any question related to Dr. Smriti's presentation? You may either unmute yourself or type in the chat. So Smriti, how should we correct nutritional deficiencies in such kids?
Obviously it would be ideal if we were able to admit this child and have a full course of intensive treatment. But for this child, how we did it was we continued whatever we could while the family was in hospital, and then we just managed to continue oral nutritional supplementation. We may not reach a point where we are able to kind of keep assessing or keep investigating for nutritional deficiencies for vitamin levels, and but in this point of view, because we were quite sure that this child is going to need more of home care, especially because that is what the family's wishes are. And it's going to be, even though we know that it's possible for us to be able to do a little better if the child is admitted in hospital, we have to end up going with the family's wishes and try to kind of continue care as well as we can. And just because the family isn't sort of responding to exactly the kind of care that we want to give them, that doesn't mean that we end up abandoning that child and not give any kind of medical care at all.
So why was this child severely malnourished? If he
Yeah,
was
so
fed-
yeah, Dr. Vijayalakshmi has asked that what was the reason, because feeding is a problem with this child. And so, ideally we would want to go ahead with a G-tube or an RT. But even if you do end up putting in the RT once, how are you going to ensure that the family keeps going in to put in the RT? And so this way we at least have a continuous line of connection with the family, and we are able to try and manage as best we can with whatever resources they can. It's quite possible, in fact, for this family, just the financial resources for being able to, keep changing RTs or for a G-tube, it was quite difficult for them to undergo. And so we decided that sometimes you have to make that compromise, but at least the child is keeping on getting the basic kind of care that we can give.
And Dr. Sangeeta is asking about HIE babies or severe meconium aspiration. When they're on ventilator, how to counsel parents?
So for these babies also, a multidisciplinary approach would be best, because it would be the neonatologist who would be in a better kind of position to be able to explain prognosis, even if it is uncertain, to be able to explain prognosis, to be able to explain the different kind of treatment options available. And it's very useful if the palliative care and the home care team are able to sit in on these discussions, because then we are able to kind of bring in the aspect of what we can offer in the form of home care, or what we can offer in the form of end of life care, if it is such. Again, in this case, I think that the parents would look to the primary medical team for the initiation of the counseling at least, and then the rest of it can be kind of taken over or be a shared responsibility between the palliative care and the NICU. Dr. Vero, anything else that you would like to add?
No, I don't. There is a question about providing a diet chart.
Yeah, so for this family, what we did is we ended up liaising with the dietitian. The NRC feeds are not really available for home care because they are supposed to be administered in hospital only. And so then we went back to the hospital dietitian, and we kept sort of going back and forth between the family and the dietitian. So the child is on home care. The child is on home visits about every month, gaining weight, still sort of the family is able to kind of do the basic physiotherapy to avoid contractures, still not on RT, but we are doing, this kind of liaising for them right now.
I think we have to move forward with the next presentation.
Okay, thank you, Smriti. So, hi everyone, I'll be talking about a child with leukemia, and I'm actually part of the Golden Butterflies Children's Palliative Care Foundation, which is an NGO, and I work in their home care program. So this is the case of a 9-year-old boy who had a history of a fall and then multiple bruises which were not resolving. And parents got worried. He was investigated, and the diagnosis was ALL. He was given chemotherapy from December of 2021 to February of this year at a government hospital here. Unfortunately, and to be honest, very unexpectedly from the parents' point of view, he had an early relapse in April 2023. And the parents were advised that there is no curative therapy, and suggested alternative mode of treatment or palliative care was offered to them. And they researched and decided that they're going to go for Ayurveda and Unani and palliative care. Next slide, please. So as a palliative care NGO, we got involved. The main symptoms this little boy had was mainly pain. There was generalized body pain, and then when on examination, he complained of tenderness in his right clavicle and right chest wall, and then over both legs. pain was continuous, aching, pulling type with a numerical rating scale of 8 out of 10, and it wasn't responding to tab paracetamol Q6 Thali. The oncology team at the time of the child's discharge had put him on oral steroids, 25 milligrams TID for 10 days. There's also inability to sleep because of pain and fatigue. And fatigue is actually something we don't consider too much of when we look at symptoms in a child. I'm seeing, yes, thank you. And this symptom, it may not be top on our list to manage, but it is very significant from the child's point of view. Children, they don't want to sit still. And fatigue, this tiredness, this weakness, not only sometimes physical fatigue, but mentally and emotionally, just fatigue, really affects their quality of life. So that would count as a very important symptom to ask and also to manage. And also he had episodes of fever. Next slide, please. Now, that was at home, but within a few days, the pain that had increased and just not being managed with paracetamol, the parents admitted him back into the government hospital, and they did an MRI, which showed abnormal bone marrow signal changes involving the dorsal, lumbosacral vertebral bodies and the pelvic bones with contrast enhancement, which features suggesting of a relapse. At that point, his hemoglobin was 5.7, but his platelets were okay. So he received Paxil red cell transfusion, treated with IV tramadol in hospital. They don't have morphine. And then we were able to get morphine. And so he was started on morphine, 5 milligrams Q4 Thali, 10 milligrams at night, with 5 milligrams as a breakthrough pain dose. Along with that, of course, we always give a stimulant laxative, Dulcolax, and also Clemafin syrup, which contains a stool lubricant and osmotic laxative. Domperidone to control any symptoms of vomiting when you initially start morphine. That can be for a couple of days. Next slide, please. So back at home, unfortunately, his pain was not very well controlled. And this was mainly because of compliance issues. And that's another thing we have to deal with, because when you come back to home, and unlike in hospital where we can usually control what the child is getting, but once they're back home, well-meaning friends, relatives, everybody on earth will be suggesting a whole lot of, medications and treatment modalities, all in a desire to help. And since the parents had chosen an Ayurvedic system, there were a lot of timing issues. The Ayurveda doctor guaranteed cure within 40 days if the timing and the correct medication was followed. And no matter what we told them that, looking at his physical state, looking at his blood findings, looking at his MRI, that it looked like the disease was progressing, they were very convinced that the Ayurveda doctor could deliver on what he had promised. And one of his main criteria is you should not give him any pain medication or any other sort of medication within 2 hours, at least wait for 2 hours after the Ayurveda medicine, which meant that pain medication was never given on time and many times just omitted. So every time the mother is calling up saying he's still in pain, and every time we're asking, so when was the last dose of morphine? And not able to say for sure, was a rescue dose or a breakthrough dose given? Was not happening. Child also progressively found it difficult to walk. Severe pain in both legs, was limping. And so the team, the home care team, he was being carried from the bed to the bathroom. And most of the time, the mom is at home alone with him. She found that difficult. And so we gave first of all, a wheelchair because he still wanted to go to the bathroom. So she would put him in the wheelchair and wheel him across. And then later on, of course, that progressed to him wearing a diaper most of the time. He was pretty irritable with frequent fights with his siblings. He's got a 1-year-old little sister and I think a 3-year-old little brother. And even while we were visiting, we can see him giving these subtle pinches to the children, and they will start crying. And then, so he was pretty irritable and he was kind of spoiling for a fight. His appetite was good and he really was someone who enjoyed his food. But Again, the other treatment regime mandated that he be on a complete vegetarian diet, which he hated. And because of that, there was a lot of food refusal and tantrums around food, which was an ongoing battle and creating a lot of friction at home. Sleep again affected due to pain and this fatigue. He was a very active boy. In fact, he never used to sit at home. Every chance outside the house. It was only a 2-room house. So he liked to spend his time taking a little cycle and going around on the little street outside and, going to friends' houses. So, and the fatigue and not being able to do anything, I think added to his frustration. Repeated episodes of fever were there. And one of note was in June, yes. He had one episode of hematuria, and then mom also said there's mild scrotal swelling. She wanted to have his bloods done, and she was very prompt in that. Any sort of change, she'll say, I'm going to get his bloods done. And that was one way I think she felt that she could contribute to his care. And the hemoglobin was 8.1, platelets were 69. Urine microscopy, there was no growth. So mother wanted admission for transfusion. And we were able to say that, at 69,000, and since it was a one-off occurrence of hematuria, he may not need that transfusion, and to be able to avoid too many transfusions or for not the right reasons also. But a lot of reassurance was given that we will monitor, let's see, things like that. So we had to give that ongoing support. Just a bit of family background. The father's 38 years old, he's a driver, mother's a homemaker. This child has a 12-year-old sibling who's got empty cell syndrome, and he's on growth hormone injections. And of course, he's got a 2-year-old brother and a 1-year-old sister. They are economically stable, very small house, but they seem to manage, and relatives were willing to give a bit of financial help. A big belief in God that he would heal the child, and extreme disappointment with allopathy, and a feeling of having been betrayed by the doctors, because in their mind, and that is something we have to realize when we speak to parents at initial diagnosis also, that during ongoing communication and diagnosis, that the first time they might hear only a certain amount of what we say. So sometimes that has to be reinforced with many more sessions, and also sometimes written down. And sometimes we need to ask them to say, so can you just tell back to me what we just spoke about, so that we can know whether what they say, what they have understood is the same thing as what we have said. So many times a lot of miscommunication leading to mistrust happens because communication needs to be ongoing. And if we ask them, why didn't you speak about it a little earlier to your treating doctor, they'll say, oh, they're so busy on rounds. When they come, they have so many children to see. They spend 2 minutes with my child. How can I disturb them? Things like that, So also from our doctors on our behalf, and especially palliative care team can help in that, facilitating conversations, making sure there's been communication has taken place, where everybody's understood things is important. So these parents were at a position where they refused to accept the relapse and the poor prognosis. Next slide, please. So our job as a home care team, and we involve the doctor, there is a nurse, and a social worker or a counselor. So it's at least 3 of us going to the home. And one of course, very major important thing as a team is communication. Establishing rapport, listening a lot, compassionate presence, and trying to see how much of the prognosis the family has understood. What do they understand about what stage of the disease trajectory the child is on? Okay, because only with that basic understand can we progress to how aggressively are we going to treat anything, how we will kind of balance risks and benefits of any medication or treatment. Okay. And also to be able to put in anticipatory planning and crisis planning. So we know that a child with leukemia could progress to having severe pain, uncontrolled pain, might have mucosal bleeding, which for some are even more disturbing for the people around them. if there's an intracranial bleed or something, it could be seizures. At the end of life, there could be breathing difficulty, child may become pale, drowsy, all those things. So to be able to educate the family on what to expect, and also any sort of crisis that could happen and what they could do at home. So for all of these, we set up a plan of action. What can you do at home? When should you call us? And then what can be done even by us? Okay, so that they're very clear, so that they don't panic. Okay? And anytime you write, for example, mucosal bleeding, if he starts bleeding in the middle of the night, what are you going to do? So you give them, talk to them about and write it down. Give them a little packet with the tranexamic acid, a small little black towel, things like that. So they know, okay, step 1, do this, step 2, do this. If it's bleeding, if it is seizures, make sure they have a kit with maybe intranasal midazolam, one little unit of that, and for all of this, make sure that we also talk about the non-pharmacological aspect of it, okay? About positioning, in seizures, about breathing difficulty or dyspnea, what can you do? Again, positioning, about fan, blowing the fan, so many things, for fatigue, it could be about, pausing and planning activities, correcting anemia, things like that. So we are discussing each of these things. Unfortunately, for this particular family, they were not even willing to listen to all this, because they were like, that's not going to happen to our child, because he's on his way to being cured. That was a very strong thing between April. He passed away in the beginning of July, but between April and May, June and all, it was pretty difficult. And you just say, all right, okay, if they're not ready for that conversation yet, even then you still continue to visit and offer other ways that you can help them. Pain was unfortunately extremely difficult to manage till the last month or so, when the mother was willing to start breaking the Ayurveda routine and giving pain medicine at the right time. Till then, it was, to be very honest, the child suffered unnecessarily, but we don't tell them that, because that's just going to create guilt. That doesn't help anybody. It was just this desire for the child's life and wanting to see him live and prosper was so much that they were just totally blind to anything else. But we continue to be supportive. We continue to visit. The issue about giving blood transfusions and platelets kept coming up. And again, that is something, of course, the mothers, especially because they've been in hospital with these children over so many months of the past 1.5 years, they have seen that it does give benefit. And so they are all for it. And we always talk to them about, okay, that was then, he was a lot healthier. His body was different, he was fighting the cancer, the drugs were on going board, and giving the red blood cell transfusion and platelet transfusion helped the course of chemo to be finished so that his body could be strong enough to be able to tolerate the chemo. So we wanted to support his functions, and that was fine. Now, towards the end of life, his body is different. His body is not responded, and so we have stopped the chemo. It is in a place where even if we give the red blood cell transfusion, it would still progress to an inevitable stage where it cannot fight anymore. So again, we don't say that, what's the point of giving blood transfusion? We'll say, let's look at the risk versus the benefits. The risk is, of course, that all of these children are like pin cushions. And if you walk into a leukemia ward every morning, every child in every bed is crying because they know that the doctor or the phlebotomist or the nurses, just going to be approaching their bed. So this is anticipatory, the anxiety and the crying. It's just a part of the thing. So packed cell transfusion or platelet, you need to get them back into hospital. And this family lived about an hour away from our office, and probably an hour and 15 minutes away or so from the hospital. Getting them into the hospital, admitting them, again, searching for an IV line, okay? Always the usual standard risks for any sort of a blood transfusion procedure, okay? And then, of course, returning back and then having to do this again maybe later, versus many mothers will say, but he was so much more brighter after that, he was less dyspneic, and especially if it's symptomatic anemia, you can see the benefit. Sometimes you can end up with fluid overload, that itself can cause problems of dyspnea. So to be very careful in how much volume to give, whether he can tolerate all that. So sometimes we'll say, okay, let's see whether he will benefit from it this time, and we'll take it from one situation to the next, okay, and go along with the parents, because for them, anything to give their child a little better quality of life, they will want. Towards the end, the child himself might say, don't take me back to the hospital. I don't want to get poked. I don't want a transfusion. I just want to be at home. Or the parents themselves will say, well, actually, the last time we gave the transfusion, didn't really see any benefit from it, from a symptomatic point of view. And is it really worth it? What can we do? Something else that we can do to take care of him, to show him that we love him, kind of thing. So that is there. Our once a month visits became twice a month, and then weekly, and with, of course, 24-hour phone support. Next slide, please. There was a big psychosocial issue here because this child had a habit, and I don't know whether it's just picked up from, a learned behavior, that every time he didn't get his own way, he'd say, I'm going to go to the terrace and jump off the terrace. Okay. So, and unfortunately, one time we had left the home visit and gone away, and after half an hour, the mother called us in a panic saying he shut himself in the bedroom, and we're all knocking on the door, but he refuses to come out. Okay, please come. We don't know what he'll do in there. So we came back, and our male social worker had good rapport with this child. He's only 9 years old, but then he started knocking on the door and talking to the child. The child opened the door. Okay, and then we got the family into the other room and let the social worker talk to the child. And so social worker asked him, what happened? And he was like, I'm fed up. And he says, for some reason, my dad yelled at me, and he said, he told me, why don't you go up to the terrace and jump? And it was a bit of a shock for the child. I think for the first time, the things that he used to say just like that, his father said. His father said out of a great deal of frustration, because this child tends to fight with the other children, maybe again because of frustration. So there was a lot of counseling needed for the child, and a bit of, how do you say, facilitated conversation between the child and his parents also. Every visit, we always take art and craft activities for all the children, and that is very helpful, because to be able to talk to the mother, even for me to spend some time with the mother talking about the medication and the child's symptoms, the other little ones especially need to be engaged, and that's why the social worker and the nurse, they plan for craft activities of very different age groups, as you can imagine. A 12-year-old, 9-year-old, a 3-year-old, 2-year-old, and a 1-year-old. And games to play with the child patient. He likes winning, so, to organize little games, lying in bed kind of games, but so that, it gives him a bit of joy, it gives him a feeling of control. And counseling for parents included some respite options, because trying to take care of like 4 children with one seriously ill child is difficult. Unfortunately, we don't have a hospice yet in Chennai, but we would have thought one of those options would have been a small time in the hospice place for everyone to kind of get a bit of relief. But otherwise was sending the younger kids away to, a family member's house and things like that. We also invited them to be part of the group family counseling that we offer for parents, that they come to the center and counseling where they can discuss their frustrations, their issues, and in a supportive environment. So the child passed away on 2nd July and just got progressively drowsy and weak. But what the mother was highly impressed with was that he, a couple of days before, he asked for forgiveness from the entire family. We visited and also called, and unfortunately there was a lot of parental guilt, because I think as they put it, we should have listened to you. We kept thinking that he would be saved. We never let him eat biryani. He always wanted biryani, but because we thought, it's important more that he gets the Ayurveda medicine than has biryani, we denied him that and things like that. So we had to very gently address this guilt and talk to them about the love that drove their behavior, and how much that was appreciated, and how in the end the child and the parents were very close. In that last couple of days, they had grown very close to each other. We were invited for the funeral function, and then just this October we had called them because we are organizing a big function for children palliative care needs from all our entire organization, all our children, and they came gladly and volunteered, and they made biryani also for them. Yeah, that's the end of my position. Slides.
I know it's been a long session. Smriti, do we have 5 minutes or do we wrap it?
We have time, but I would also like to ask if anybody would like to take questions, if anybody had any questions, because this was a very difficult case, Dr. Sabita. I can see that it was quite a tough case for everybody involved. And yeah, as Dr. Deepika said, it was a very emotional and sensitive case. So while I just drop slides for Ishaq's session, maybe if there are any questions, you can go ahead.
I particularly like the idea that the fact that they brought biryani for all the other children on the 2nd of October as a way of redeeming themselves for not having given to that child. And that's very soothing and therapeutic.
Yes. I mean, they provided, we were raising money for palliative care. So they did the biryani stall.
I see there are no more comments. Smriti, shall we just take 5-10 minutes maybe to finish that last?
Dr.
Ishaq, your audio is not very clear.
Dr. Ananya has a question for you, Dr. Sabita. How does the team keep up morale through these scenarios?
That's a very good question, because that's one of the things about palliative care. One important thing is to team debrief and how do you say, talking about and encouraging, because each team member can bring this their perspective on it and their encouragement to the rest of the team members, and reminding ourselves of why we are doing what we are doing. Also very important is self-care. Sometimes when we see all of the things that they are going through, we think like we have it so good, so it's okay to neglect self-care. We're like, okay, we won't eat because we need to go to the next house and all that, but that doesn't help at all. So taking care of self, taking care of each other is very important. Most of it is just talking it out and realizing that we are not God. Okay, we received a child who is in palliative care, and we are what we have done is added an extra layer of comfort, and improve their quality of life. Yeah, one more question is how to address denial by family. Should I take it or shall we go on to Smriti, you're muted.
We have about 10 minutes. I think let's let Ishaq present, and then we can maybe come back to it if we have time.
Yeah, we can also take it in our WhatsApp.
Yeah, Dr. Sabita, you can just put it in the chat. You can just text in the chat till Ishaq starts.
Smriti, am I audible?
Yes, go ahead.
Yes. Next slide. So I'll just breeze through few of my slides. So it was a child who was admitted in a government hospital in PICU. So this story is about a 12-year-old adolescent male who was diagnosed with stage 3 TB meningitis.
Sorry, Ishaq, could you speak closer to the mic? Closer to, because your voice is very soft.
There is no mic, unfortunately. Give me a minute. I'm just trying to join from another device. Give me just a minute.
Dr. Savita, would you like to take the question on denial till then?
Yeah, that'd be better.
Oh, okay. Okay, so denial is actually a protective mechanism. It's not that parents are being stubborn in you're presenting all the facts and they're just being stubborn about not accepting it. It is a protective mechanism because the alternative is to accept that my child is going to die, basically. And that is so painful. That's an automatic protective mechanism against the pain of loss. So when we deal with denial, we know it's going to take time. So we have to sometimes back up a bit and say, so what do you think? No, I cannot believe it. That cannot happen to my child. Okay. And we'll say, okay, so what do you see happening to your child? Okay. And we work with what they think is happening. Okay. For example, say, yes, I know he's unwell, but I don't see why he cannot be cured. Okay. Then we work on that phrase, which is, okay, let's plan for that. Okay. Let's plan for the, let's plan for the best. At the same time, shall we also prepare for the worst? It may never happen, but can we also prepare for the worst? And that phrase, however we want to put it, planning for the best, but preparing for the worst. Are you ready, Dr. Ishaq? Anytime, let me know. Okay.
Yeah, I'm ready.
You're ready. Okay. We'll come back to this later then.
Yeah. So, coming back to this child. So this was a 12-year-old male adolescent who was referred to palliative care on 28th of August. This was a year ago. The child passed away eventually and was referred in view of best supportive care. So child was apparently all right. Coming to history of present illness, presented with a history of headache and fever for 3 weeks. The child was staying in a village setting, so it took them time for them to come to the hospital. So after 2 weeks of illness, they came to the hospital after trying few of the local RMPs. So like I said, admitted in the PICU with decreased movements of upper limb and lower limb since 2 weeks, with presentation of drowsiness on 2nd of August. So on 2nd of August, in a private hospital, they gave up. They said, go to a government hospital. And after shifting to government hospital, there was further deterioration on 12th of August. And this was the initial workup. MRI showed leptomeningeal. CSF showed a picture of tuberculous meningitis. TB PCR was positive, and meningitis was made. Just to display, these are the various stages: stage 1, 2, 3. So in the stage 3 came with seizures. There was deficits, also paresis. The child was in stupor, and with a GC a score of 8 on 15. Next slide. These were the initial vitals. Child was maintaining on saturation with nasal prongs 1 liter. 30 kilos, had lost considerable amount of weight during the stay in the hospital. 3 kilos loss. And on systemic examination, we found out that there was crepitation on the right upper lobe. There was aspiration pneumonia. And like I said, in CNS, there was spasticity of both upper limb and lower limb. There were no other findings in abdomen or CVS. Next slide. So course in the hospital was started on multiple antiepileptics, trying to contain the seizures, and also intravenous antibiotics was being given for lower respiratory tract infection, and anti-tubercular medication was also started. Was being given through RT. Oxygen support was continued, but there was more and more requirement of oxygen over the course of treatment. So we did keep the family in loop. We did give them warning shot saying that there could be a need for further escalation by the treatment team for respiratory support. Next slide. So psychosocial assessment, we found the parents were in denial mode because this child was totally all right for 12 years and had never a problem, was never admitted in the hospital. The family was very much strained financially because they spend a lot of money in the private hospital, and there was a discordance between parents because one of the doctors told that they brought the child late to the hospital and it would have been helpful if they brought him earlier. So that kind of talk is not helpful for the family. We need to keep in mind that it's better not to bring the conversation regarding blaming the parents for the child's condition. And child was unconscious, not interacting with caregivers for last 2 weeks. That was also part of a huge distress for the parents. And initially, it was incomprehensible. And at the time of admission, was not communicating at all. Yes, it seems like TB encephalitis. Initially, that was the initial diagnosis, TB meningitis. Next slide. So palliative care got involved with the family. It was pretty late. It would have been ideal if we got enough time with the family. But then again, better late than never. We identified an advanced care plan. Planning was done. We identified the decision makers. That is most important. Try to discuss how the illness trajectory could be, because many a times not knowing and that uncertainty in the family members itself can lead to a lot of distress. Goals of care, identifying it is very important, whether it is of cure. When we first time saw the child, it didn't seem that the child could be cured because there was severe impairment. Also, there was, and also need to know whether we need to prolong a good quality of life or whether it is to provide good end of life. So over a period of time, we did get a sense that the child would deteriorate because there weren't any signs of improvement after giving the curative options. We need to think about crisis management also, if there is any untoward symptoms or signs that can develop. And also in advanced care plan, we do talk about end of life care issues as well as serious illness conversation, which was dealt by Dr. Smriti. Next slide. So in subsequent days, though we tried to get do not escalate kind of a guidance, a consent, but still the child had to be put on ventilator because there was no other consent from the parents to not escalate. And the child was slowly deteriorating and going into respiratory failure. Child was not maintaining vitals or blood pressure, requiring him to be started on inotropes. So NORAD was started, dopamine was started, and communication about prognosis and breaking bad news was done. Next slide. And as the days progressed, the child's condition deteriorated. In the end, we sat with the family. We told that we need to take a consent from you, whether to resist it or not. The family did understand the grave nature of the prognosis, and they did agree for not to resist it and not to escalate further. And child had a cardiac arrest on 10th of September. CPR was not done, and comfort measures were provided. The child was given to the parents. Dignity was maintained, and tubes were removed properly. And we did follow up them, and bereavement support was provided. What I want to tell regarding next slide. What I want to bring out from this scenario is there might be few things, even though you don't have resources in your hospital about having a team with palliative care expertise. We want you to become the generalist palliative care physician and also take up few things. It is not very possible to do bereavement for a child who's passed away for the family, but many a times it could be just a phone call from your side, maybe 2 weeks after the death of the child. It is very much helpful for the family to cope, to feel that there is someone to actually call and inquire. Many a times you can get in touch with them and connect them to support groups or parents who have lost their loved one also. So just to summarize, these were the various role of palliative care unit. Initially think about assessment and management of symptoms, also provide assessment regarding various issues, talk about prognosis in a very honest and clear way so that they understand, try to make an advanced care plan, talk about whether we want to escalate further treatment or not, and if you feel that any kind of treatment is futile, try to have a do not resuscitate guidance in place, because you don't want to resuscitate a child in whom any further escalation is going to be of any help. And try to so that they can get in touch, try to provide some bereavement call. A call can be helpful. And always think about, if there is an end of life scenario, try to comfort as much as possible the child as well as family. Next slide. So with this, I finish this scenario. Any particular reflections or any other thoughts? You must have come across a lot of children who are there in PICU, where you have felt totally helpless because you don't know what to be done. You know the child is deteriorating, but still there is something to be done. So any reflections, any thoughts?
Ishak, there is a question on DNR in the medical legal system.
Very important question. So there are guidances regarding by ICMR about DNR and not to escalate also. In my setup in Apollo, what we have found is we do have DNR forms. They do say it is not a complete protection, but still it is still a good document to have, where we can't push a particular amount of treatment if it is futile. So that is what the consensus is. But like I said, if you have
Ishak, you muted for some reason.
We can't hear you, Ishak, for the past half a minute. I think his sound system is gone.
Yeah. So I'll just take that up. There is there are guidelines on DNAR in that have been published by ICMR in 2021. A few hospitals have taken that up and incorporated them into their end of life policy or into their hospital policy. Now, what legal guidance most hospitals have had says that if you are doing if you are sort of practicing what is current established medical practice, and if there are ICMR guidelines around something, that means that it is established medical practice, then that means that even if the case goes to court, it will not be, if you are doing what is in line with current medical practice, there is really no grounds for you to be sued or penalized in any way for it. So we don't have laws per se on the DNAR, but then very few countries do anyway. Sindhura wants the DNAR ICMR guidelines. Okay.
We'll put it in the group. Sorry, I got inaudible. So yeah. Any other doubts? We will keep in the ICMR guidelines so that you can also tell in your hospital that this is something that is that can be used in the legal framework. Any other questions?
You may want
Does
for
anybody, sorry,
Yeah, Dr. Prashant.
can I speak? Yeah. Yeah, myself, Dr. Prashant. I'm speaking from the Alda, assistant professor in medical college. I just like to know, does anybody sued anyone for this DNR sort of care in India? Does any case happen before, so yes, we can get some idea about it?
Ishak, you want to take that?
Smriti, I did not get the question clearly. Did you
The
understand?
question is, has there, you want to know if there has been a case regarding DNAR in India, right?
Yes, yes. Does anybody went to the court because against the hospital, this hospital is any policy or anything?
Not to
I
our,
haven't come across anything. Yeah.
not to our knowledge, but I think that there was a in the last few years there was a case that went to Delhi High Court about one hospital keeping the child on ventilator after being declared brain dead, and so the
Okay.
hospital had to be was penalized for that.
So again, this is quite controversial, na? Yes, sir. This is ultimately what we can say, because we came across we have some sick patient here referred from even Andhra Pradesh or many other districts, because where are the tertiary healthcare center in this 5 district. So most of the patient, I vividly remember one case came from the Karimnagar. The patient is having a huge infarct, and there was no flow beyond middle meningeal artery. And when he came at that time, only there was a huge midline shift, and he has intermittent decorticate posterior. So nothing we would have done for it. So we ventilated him. We give chance to the parents. So only we can give the supportive care. But after 2 to 3 days, they went home. So this is it's depressing for us. We cannot do anything for such cases. But again, we have to think about what is the legality of this. So that's why this is my concern is, if anything has happened, that could provide us the further better handling of such things.
So I just want to give a short comment. So the thing is, if you are providing a clear, honest communication regarding the condition of the child, and without any doubt, if you show the futility in the treatment, no one can come and sue you. For example, we had a child with SSPE, which is subacute sclerosing panencephalitis, which is 100% mortality. So court also understands the issues from the doctor's perspective, that if the treatment is in futile nature, and if we clearly know that the child is not going to be benefited by the treatment, as far as what I have seen in the legal system, the courts have also been on the side of the doctors when the documentation, when the condition, and when the various team has been taken into consideration. So one doctor's opinion wouldn't hold that huge of a thing, but if you have 2 or 3 doctors, team of doctors who have clearly stated that any particular treatment is in the futile area, then courts have also been on the doctor's side. So
Okay.
it will be helpful if you have a team of doctors, consultants, and also if you can clearly state that this condition is not going to be benefited by any further escalation of care, we are protected.
Okay, so it's basically end of life supportive care is the decision of parent rather than the doctors.
So again, a very good point. The thing is, parents can't be the people who direct the treatment. For example, there can be a child who's on chemotherapy, relapsed, and they can't come and tell that, no, you give chemotherapy. If in the guidance and if you're seeing a risk benefit ratio, there are treatments that will benefit the child, and you as doctor can suggest them. But then again, just because parent is telling us to give the medication, the reason why I talked about cancer is many a times we find parents coming and telling us, sir, give more chemo, which is not something that is beneficial for the child. So based on their thing, we need not give chemo. So it depends on our clinical judgment and not through the parents thing. But then again, regarding DNR, quite a few hospitals, we do need to get consent from the parents. Like Dr. Smriti told, ICMR guidelines, we will put it in the group and maybe we can have further discussion around it. But yeah,
This is
we do
actually
need to
pretty
have
much the
consent from the
gray
family.
area. This is pretty much the gray area. Means ultimately it's understanding between, I think, treating doctor and parents, how they have communications.
Yes,
Yeah.
exactly.
Okay, thank
And
you.
when-
Thanks a lot.
And when we talk about DNAR, we are only talking about no CPR. It's very limited, actually. So following the guidelines of ICMR, in order to adjust it to your own setup, especially for pediatrics, we need to change. It would be father and mother, maybe, who need to sign. At least in our hospital, we did it like that, to have 2 signatures. But and then we are covered by the, legally speaking, we have the Supreme Court judgment of 24th of January 2023. So we are very much, I mean, there's no worry about that. The DNAR form is signed by at least 2 doctors and 2 parents or 2 relatives, and none of them is going to sue you. If it is other relatives, distant relative, the uncle coming from the US, it's very easy to sustain
So
opposition.
I have one. Yeah, thanks a lot. I have one more little bit doubt. See, being doctors and higher graduates, all those things, we can sensitize the basically over the period of time we get sensitized to all those things. But how you sensitize the nurses, physiotherapists, and all other people to take a look at a compassionate means they might say that this ultimately this patient will going to die. Why we are doing so much for them? So how do you make them sensitized to do the day-to-day work?
Dr. Vero, would you like to?
Hello?
You're muted.
How do you sensitize the nurses, physiotherapists, allied professionals for the day-to-day
Yes,
work
yes,
of children with severe illnesses, you are saying?
yes,
So
yes.
sensitization will start probably with theoretical classes. Like if nurses give classes to nurses, it's much more powerful. You get a social worker or counselor to pitch in also. That is very helpful. You can even, we do have training sessions for the security staff and for the, even for the cleaning staff, those who are in charge of cleaning the body of the children who have died. So to exercise a bit, I mean, to increase their sensitivity, and they're very receptive and very grateful for being given attention. So there is the theory and there is the practice, which is the example that we give. And that by seeing the way we deal with those families and the way I don't know, in a particular case, that particular nurse, we inform her, try to deal with this family in this way, that way. So it takes a bit of time and patience, but we do make a difference, and they realize it, and they may change their ways also of dealing with those type of patients.
Okay, thank you.
I think we well overshot time.
Yeah.
It was very engaging.
One point I wanted to add, Smriti. See, you might come, all of you might come across cases and scenarios where you are in a dilemma. You can please get in touch with us to know what can be done rather than feeling helpless. And there was one point regarding salvage chemotherapy. I just wanted to clear. We can give salvage chemotherapy. We can give any form of chemotherapy based on the clinical expertise of the oncologist. What I meant to say is, just because the family is asking for chemotherapy doesn't mean that we go and give chemotherapy. That is what I meant. So if based on the treatment guidelines, if you're following the proper treatment guidelines, you're totally safe. I didn't mean that though treatment guidelines says chemotherapy, not giving chemotherapy, I didn't mean in that way. So yeah.
And if I may add to you what you said, Ishak, metronomic oral chemotherapy works wonders in children. So in most of the cases, parents are very open to this idea that we shift from injectable chemotherapy to low dose metronomic chemotherapy orally. It's very well received. But even this may have side effects in terms of mucositis and leukopenia, and we may have to reduce it or stop it at some point. But it helps in slowing down the progression of the illness, especially in solid tumors, but also in leukemias. But that is done by the oncology department.
Great.
Okay. So thank you all for a very engaging discussion, and we hope to see you again next Saturday. Bye, everybody.
Thank you. Bye bye. Thanks
Thank
for
you,
staying
Susie.
so long.
Thank you, everyone.
Thank you.